Hi, I am Ali Al-Khathaami. I'm a stroke neurologist. I work as a stroke program director at King Abdulaziz Medical City, Riyadh, Saudi Arabia. What I'm going to do over the next 20 minutes, I'm going to review with you the intracerebral hemorrhage. Let me first start to clear some of the misunderstanding about names. People are using different names and sometimes there is a misunderstanding. What I mean by intracerebral hemorrhage is the bleeding within the brain tissue, within the substance of the brain. Many people use intracranial hemorrhage. However, intracranial hemorrhage is more inclusive term that includes intracerebral hemorrhage, the one that occurs in the substance of the brain, the subarachnoid hemorrhage, either traumatic or aneurysmal, subdural hematoma, and epidural hematoma. My talk today is going to be around the intracerebral hemorrhage, which is basically around 10 to 15% of all the cases of stroke. We classify intracerebral hemorrhage in different ways. If you wanted to classify it according to the mechanism or the underlying etiology, then we say it's either primary or idiopathic or spontaneous. All are the same terms. That include the hypertensive, which is the most common, and amyloid angiopathy in the elderly patients. The secondary intracerebral hemorrhage, there are many causes. The most common are trauma, vascular malformation, bleeding within a tumor, blood thinner or coagulopathy, moya-moya disease, vasculopathy, cerebral venous thrombosis, and so on. But there is another way of classifying intracerebral hemorrhage, and that depends on the location of the bleeding. And that also has a diagnostic and prognostic value for this kind of classification. We tend to classify intracerebral hemorrhage into lobar, which is basically occurring in the superficial area of the cerebrum, i.e. in the cortex. And this type of bleeding tends to be an older patient with mild cognitive impairment and tends to be amyloid angiopathy related. The other types is subcortical, in the deep tissue of the brain, which is basically in the basal ganglia, in the thalamus and brainstem and cerebellum. Typically those are related to hypertension. The most common location for hypertensive bleeding is the basal ganglia, particularly in the putamen. I'm going to skip the pathology of hypertension-related intracerebral hemorrhage. We're going to focus on the clinical aspect of the disease. If you look into the outcome of the disease, it's quite bad. All the intracerebral hemorrhage cases, if you look at them as 6 months down the road, you will see 40% of them are dead, while the another 20% are actually independent. It's a very killing disease. Only 40% are dependent with mild to moderate neurological deficit. Now, let's look into who is going to do good and who is going to do bad after intracerebral hemorrhage. There are predictors of mortality at 30 days. And the most important predictors which makes sense, is the size of the bleeding, which is the hematoma volume. In all the studies that have been published, a volume around 30 ml more than 30 ml predict mortality. If you have your patient coming with decreased level of consciousness, or there is an intraventricular component of the bleeding, i.e. the blood goes extend into the ventricles, and also arterial pulse pressure. All these are predictors of mortality at 30 days. And if you look at 6 months down the road, the most important predictor is age. If the patient is older, he's more likely to die.